Well, I think we'll go ahead and get started. Welcome, everyone. Welcome to today's webinar, the Build Back Better Act. What are the implications for older Americans with chronic conditions? This webinar series is coordinated by the Aging Initiative, which is an NIA-funded initiative that bridges the expertise and leadership of two powerhouses for research on multiple chronic conditions, the Healthcare Systems Research Network and the Claude D Older American Independence Centers, or PEPPER centers. The Aging Initiative is led by Dr. Jerry Gurwitz at University of Massachusetts and Myers Healthcare Institute, along with co-PIs Elise Adams and Jay Magaziner. My name is Leah Hanson. I'm a senior research investigator and senior director of research at HealthPartners Neuroscience Center, HealthPartners Institute, and co-director of research at the HealthPartners Center for Memory and Aging. And I'm part of the Aging Initiative Dissemination Workgroup, co-led by Heather Whitson at Duke University. Due to the number of registrants for today's webinar, we have placed phone lines on mute to reduce audio feedback. However, we really encourage audience participation using the chat function. If you have technical or logistical questions, we ask that you submit those in the chat to Chris DeLude and Ivan Abialis, who will be monitoring the discussion. We extend a huge thanks to Chris and Ivan at Myers Healthcare Institute, who work behind the scenes to make these webinars possible. And now I'd like to introduce today's speakers. Katherine Hayes is the Director of Health Policy at the Bipartisan Policy Center. At BPC, her work is focused on healthcare reform, chronic illness, and long-term care. Prior to joining BPC, Hayes held the position of Associate Research Professor in the Department of Health Policy at the George Washington University School of Public Health and Health Services. Her government expertise includes serving as health policy advisor to members of the Senate and the House of Representatives in both political parties. Her accomplishments as policy advisor include enactment of legislation to establish federally qualified health centers, severing the link between Medicaid and welfare, and enactment of legislation creating the first state option to expand home and community-based services under the Medicaid program. Hayes also served as a program consultant for the state of Missouri Medicaid Agency and as health and education policy advisor for the state of Texas Office of State Federal Relations. She received a Bachelor of Arts degree in International Studies from the University of North Carolina at Chapel Hill and a Juris Doctor from the American University Washington College of Law. She is a member of the District of Columbia Bar. Today, we will also be joined by two discussants at our webinar. Kai Young. Kai Young is an Aging Initiative's MCC scholar. He's an assistant investigator at the Kaiser Permanente Washington Health Research Institute and an affiliate assistant professor at the University of Washington School of Pharmacy. Kai is a pharmacist and pharmaceutical economist with expertise in patient medication use behaviors, insurance design, and outcomes research. His objective is to develop and evaluate incentives to encourage high-value use of healthcare services. We're also joined by Barbara Kiewicz. Barbara is a representative from our Aging Initiative Patient Caregiver Advisory Council. She is a clinician, consultant, and writer specializing in healthcare innovation and works with healthcare systems to incorporate relationship-based models of care. She is the author of Love in the Time of Chronic Illness, How to Fight the Sickness, Not Each Other, and delivers programs based on her research to clinicians and patients and caregivers. She is a patient family partner at Stanford Healthcare and Sutter Health. Katherine, I'll pass it to you. Thank you so much for being here today.
Thank you very much for inviting me. I really appreciate it. Next slide, please. I just want to run through what I'm going to speak about. One, quick background on BPC and who they are, barriers to caring for Americans with complex needs, a little overview of current law, Medicare, Medicaid, and coverage of non-medical services, and then focus on the Build Back Better Act and other policy options. And then I will turn it over for questions. Next slide, please. First, the Bipartisan Policy Center was founded in 2007 by 4 former Senate Majority Leaders, Mitchell, Baker, Daschle, and Dole. Senator Daschle is still very much engaged as a leader in the organization. And I think what I could say most about BPC is that they're really different from other think tanks. First of all, they have current and former professionals or politicians, working leaders working on compromises. And these compromises are not sort of a least common denominator. They're the same sort of negotiation that you would expect to see on the Hill, on Capitol Hill, between members of Congress. You know, they really get into an issue and find compromise. And I guess the safest thing to say there is that in my experience, we usually come up with a product that everyone hates. So another thing that I'd like to mention about BPC is that unlike other think tanks, we do have a lobbying arm, BPC Action, which is our 501c4. So I'm on the C3 side and work on putting together policy recommendations. And then we hand it off to our C4 and they take it up to the Hill or to the agencies as necessary. Next slide, please. When we first started working on chronic care, we did a lit review and determined, and I'm sure other people doing a lit review would come up with could come up with additional items, but we identified the key elements in successful care models for caring for those with chronic conditions, and then identified the barriers. Because our focus is on federal policy, those are the areas that we worked on. So targeting models to patients with multiple chronic conditions and integrating both medical and non-medical benefits. And some of the barriers that we identified were eligibility, because Medicaid is primarily limited to low-income individuals, and payment rules and policies, particularly before the Bipartisan Budget Act of 2018. Next slide, please. I'd like to talk a little bit about coverage of non-medical benefits in the Medicare and Medicaid programs. And the reason, before I do that, the reason I want to focus on Medicare and Medicaid is really for, I worked for a member of the Senate Finance Committee, which had jurisdiction over Medicare and Medicaid, and found early on that often it is easier to get things done through entitlement programs because the resources are so much better. So for example, when I worked for Senator Chafee, Sarah Rosenbaum, who was then a consultant for the National Association of Community Health Centers, came to me and she said that they were concerned because the community health centers were not getting enough money and they were having to spend their resources on Medicaid patients instead of their mission for covering the uninsured. And so what we did, and it was actually all Sarah, what she did was came up with something called federally qualified health centers and cost-based reimbursement under both the Medicare and Medicaid programs. Senator Chafee agreed to sponsor the legislation and was able to get it through Congress. And I was staffing him at the time. And so I was fortunate enough to work on it. And the reason this is so important is because once the community health centers had cost-based reimbursement under the Medicare and Medicaid programs, they had a guaranteed funding stream for Medicare and Medicaid for their services. So at BPC, as we started thinking about how to cover non-medical benefits in the Medicare program in particular, Medicaid has much more flexibility. It made a lot of sense for us to try to figure out a way to get more of these services covered through Medicare. So very quickly, Medicaid fee-for-service, the non-medical benefits that are covered, among others, are targeted case management services, non-emergency medical transportation, housing-related services and supports, and of course, long-term services and supports, which include both institutional care in a nursing home or home and community-based services. There's much more flexibility in Medicaid managed care. States are able to provide in lieu of services, or they allow plans to provide in lieu of services. So for example, if a plan decided that it was more cost effective to have individuals take an Uber to a medical appointment than to have them try to get to the medical appointment, through public transportation, or if it was more effective to have a nurse practitioner come into their home as opposed to having them come into the office. Those in lieu of services permit plans to cover those instead, in lieu of literally of Medicaid benefits. There are also value add services that Medicaid managed care plans are able to provide. And they include things like air conditioners for patients who have asthma, particularly children. I know in the state of Rhode Island, a very creative Medicaid or health commissioner was able to get CMS during the Clinton administration to cover replacement windows as an alternative to address lead poisoning. So as a durable medical equipment under the Medicaid program, which I think was really stretching things, but it was very creative and very well done. Other value add services include a crib, maybe for a newborn that's going home, or a car seat when they don't have one. And then also the states are able to provide under the Medicaid program, manage long-term services and supports. And those services are provided primarily through managed care plans, but include home and community-based services. Home and community-based services, I'd just like to say, as opposed to institutional care, nursing home care. Nursing home care is a mandatory service under the Medicaid program. Many of you may already know this, but for home and community-based services, that benefit is optional. And so there is not a strong incentive for states to provide those home and community-based services in some cases. Some states have been very proactive, others not so much. But one thing, and I just wanted to mention 1915C of the Social Security Act is a waiver program to allow states to provide home and community-based services instead of institutional care. And under that waiver program, states have to demonstrate budget neutrality. So they would have to show that they would spend no more, that the federal government would spend no more under these home and community-based services while providing these home and community-based services than the federal government would have spent in that state for institutional care. And while that seems like a no-brainer, home and community-based services being much less costly, the challenge became that there are many more people that are interested in receiving home and community-based services that are interested in going into a nursing home. So it became an issue, and members of Congress and often call this the woodwork effect, in which once a benefit becomes available, people come out of the woodwork and it's much more expensive. So Medicare fee-for-service, there is very little opportunity for the provision of non-medical benefits there. But in managed care, in the Medicare Advantage program, Congress passed the Bipartisan Budget Act, and as a part of that was the Chronic Care Act. And what that did was allowed Medicare Advantage plans to provide special supplemental benefits for the chronically ill. First, supplemental benefits are those benefits which are not Medicare covered benefits, but that plans have the opportunity or are permitted to offer within their plan. And they typically include things like dental and vision and hearing services, although it's not provided universally. Special supplemental benefits for the chronically ill. And if at some point, if you have an opportunity to, if you get a copy of the slides, you can click the link that I have there, and that has the agency guidance that lays out what is permissible. And this was important for two reasons. One, it was the first time Medicare Advantage plans were able to target benefits. Before, they had to provide all benefits to all individuals. So in this case, they were able to target certain benefits to those with chronic illness. And the sorts of things that Medicare Advantage plans are now allowed to provide are things like food and produce, non-medical transportation, indoor air quality, pest control, to address social needs, including major structural modifications for the home, widening of doorways, widening of hallways, and also ramps. And so this was a huge change to the Medicare program. So next slide, please. And just very quickly showing you, this is just the first year that plans were able to do it. The take up was very small, but since then we have seen some increases in 2021, particularly when it comes to adult day services, which is very important to family caregivers, as you all know. And second, I think that's it. Next slide, please. Thanks. And more benefits were offered in 2021, and we expect even more in 2022. So now I'd like to, so there's no false advertising here. I'd like to turn to the Build Back Better Act. When we first talked about my doing this program, I anticipated that the law would be passed, but as you may have all read, there's been a lot of controversy about the level of spending. It has passed in the House of Representatives and is still awaiting debates in the Senate. The key members of Congress or key senators are working to try to reach a compromise there. The House passed legislation includes up to 4 weeks of paid leave for caregivers. It allows Medicare coverage of hearing services and provides funding increases to improve workforce and training, and also palliative care and the lifespan respite program. It provided some increases in coverage for Medicaid and non-expansion states. But what I'd really like to focus on is Medicaid home and community-based services. Some of you may recall that as a part of his campaign, President Biden pledged to raise or to put forth legislation or recommend to Congress that they spend $400 billion on Medicaid home and community-based services. And that's really going to require two things. Not only does it require funding for states and incentives to states to get them to expand these services, but it also requires a lot from the state because the infrastructure is really not there. They don't have the workers' wages are too low. And not many states, particularly those states that don't offer a lot of services right now, just don't have the manpower to flip a switch and provide those services overnight. Now, over time, that $400 billion was cut back to $150 billion. And it would include a number of grants. First, $130 million in planning grants to states, and also technical assistance, which would allow CMS to come in and help states that don't have much experience in providing home and community-based services to help them get up and running. There is also a permanent expansion of spousal impoverishment and an expansion of money follows the person. Next slide, please. So it's not really clear yet what the outcome of the Build Back Better Act will be. But my expectation is that at least for the purposes of Medicaid home and community-based services, we won't really see much in terms of reduction of that $150 billion. They've already gone from 400 to 150, and I think there's every expectation that that number will hold. There are a number of members of the Senate who are very much committed to keeping this provision in there. And while some things may be cut out of this proposal, I think that they're very much expecting to continue to provide the increase in federal matching dollars for home and community-based services. If you recall, there was the American Rescue Plan that went into effect shortly after President Biden was elected. And that one of the provisions that was included in there was an increase in federal matching for states, a temporary increase for states to go ahead and expand Medicaid home and community-based services in the short term. And that was only for 1 year. And I think there was a lot of skepticism as to whether or not states would come forward and really use that money. You know, after the Affordable Care Act was passed, a number of states were not really interested in taking advantage of the increased funding to expand general health care services. That has not been the case with Medicaid home and community-based services, even when provided just for the short term. Every single state came forward with a plan to do some sort of expansion of Medicaid home and community-based services. And a lot of that, I think, is being driven by states that have not typically made those services available, but saw the devastating impact of COVID-19 on nursing homes and have realized that it is important to go ahead and get some of those services out into the community. So if this law passes, I think there is every expectation that we should see a significant increase in the availability of Medicaid home and community-based services, even in those states that traditionally have not chosen to do that. So getting back to the issue of Medicare Advantage and the ability of plans to cover non-medical services, BPC came out with some recommendations in 2019 that would attempt to apply some of those same standards to Medicare fee-for-service, because most Medicare beneficiaries are not enrolled in Medicare Advantage, and there are a number of areas in the country that there are no plans. So in the interest of trying to get services to all areas and all individuals, we proposed a number of recommendations, but one of them was to try to get some of these non-medical services provided through fee-for-service. And it was very easy, or it was much easier to do that in Medicare Advantage because they're paid a capitated monthly rate for services. And to the extent that they could provide these non-medical services within that capitation amount, they could go ahead and do that. But in fee-for-service, when Congress tries to enact legislation to expand Medicare coverage, there's a branch of, there's actually a congressional agency, the Congressional Budget Office, that will estimate what the cost of that expansion is. And they make assumptions about how many people will take advantage of that. And typically, it's very difficult to get something passed. We've seen that a point of contention in the Build Back Better Act has been a proposal by Senator Bernie Sanders to expand Medicare to cover vision, dental, and hearing services. And over the course of the debate, that benefit has been whittled back considerably, and is now, as I mentioned earlier, only hearing is still in the mix there, and it's unclear whether or not that will be in the final package. So what BPC did was set up some criteria. And first of all, we went and looked at the evidence around what non-medical services, if targeted to patients with multiple chronic condition, is there strong evidence that you could lower costs over the long term, or at least not increase cost? And the one thing that we could find, housing aside, housing has been seen to save as well, but the cost of providing those housing services within the existing Medicare infrastructure is, number one, probably not politically viable, but would also be very expensive. So what we looked at was the provision of medically tailored home delivered meals for individuals who have been discharged from the hospital within 2 weeks. And the data there was already there. Research had been done to show that it could reduce hospital readmissions and lower and emergency department visits. And also, if there are readmissions, bring down the cost of post-acute care. So we contracted with someone to take a look at that. And you can see it. I left it in other resources, but in another slide, and you can take a look at that research if you're interested. So the reason I'm mentioning this is because there is not a lot of evidence. You know, we keep hearing that there's a lot of evidence out there that these non-medical services can save money in the Medicare and Medicaid program. And that may well be true, but it's very hard to find the evidence to show that. And one of the major challenges that we found when we were looking for a benefit to run the numbers on using Medicare data was that a lot of the evidence did not include the input costs, which made it impossible for us to make the argument that overall it was cost effective to provide these services. So for those of you who are researchers, that is such a critical component. I always make a point of raising that. Next slide, please. There are some of the resources that I mentioned. The one in which I'm trying improving. The fourth one down is a review of evidence on healthcare impacts of interventions to address social determinants of health, and that's been put out by the Commonwealth Fund. I'd encourage you to take a look at it. That is the only major resource that I have seen out there, and it's one that members of Congress and their staffs are familiar with. And so as you're doing research, it might be helpful for you to take a look at that and see how few of those studies actually included the input costs, or at least that was the case when we put this together. So with that, I would like to wrap up and hand it over to the moderators and discussants and then questions. Thank you very much.
Kai, I think we'll go to you first.
All right.
For your comment.
Sounds good. Well, hello, everyone. Thank you, Catherine, for such a informative and insightful presentation, both of the current law and also this proposed Build Back Better law and its potential impacts. I found particularly what was insightful is sort of the additional information on the scope of benefits with regards to the Medicare Advantage and the Medicaid managed care population with regards to what could be considered supplemental benefits and value-added services. Those examples were very helpful. So thank you for that. I had a number of questions. One is this question. I think it's a larger question about the interface between how you sort of pitch an intervention, right? As incorporated into this Build Back Better legislation, and the degree to which it needs to be cost savings, right? The act itself, the estimates are quite substantial, right, in terms of budget. So we know that not everything in there is cost savings. Otherwise, it would be neutral or less. And so I know we also know that very few things in healthcare itself are cost savings. And to what degree can we incorporate interventions for this MCC population that are not necessarily cost savings, but do generate, important health benefits for patients, right? And I guess the context that I don't want to be naive to is sort of the politics of that. And I understand that from just as a lay person who's following the news, that there's substantial pushback because of the budget. And so if you were to insert something in the later stage, I'd imagine that budget concerns for certain interventions would be more important. The other question that I had is, you touched on this a little bit with your, I think, second to last slide about specifically about the multiple chronic condition population, the MCC population, and how to address the needs of this population. So, and as we know, the individuals in this category have substantially larger needs with regards to medication management, care coordination, continuity of care, and that there is a lack of effective interventions for this population, great need for interventions. And I wanted to see if you could comment a little bit about how this Build Back Better, if there's anything there that interfaces with sort of existing models of care with regards that the CMS is already pursuing, namely within CMMI, the Innovation Center, with regards to care coordination, primary care transformation. I know there's accountable health communities, pilot. I think that they're beginning trying to address social determinants of health, and then the value-based insurance design work as well, right? And love to hear about some your comments on some of those things.
Sure.
Thank you for a great presentation.
Oh, thank you for giving me the opportunity. I think the first issue is the question of whether or not it is possible to add interventions and have Medicare pay for interventions. And I'm assuming that you're talking about the Medicare program. and recognizing that sometimes it's just a good thing to do, and sometimes it improves patient health, and Congress should be willing to spend money on some of these social interventions. And I think that there are a lot of members of Congress and senators and other policymakers that share that view. Pardon me. On the other hand, there are a number of mostly conservatives and some mostly Republicans, but there are Democrats too, that are concerned about using the Medicare program to expand social services, particularly programs that are already funded through the federal government, such as housing. And their concern is that because there is a limit to non-entitlement services, in other words, instead of, with the Medicare program, pardon me, being an entitlement program, the government is sort of, once something's covered, it's sort of on autopilot, and those services are covered until the law is changed or until the agency is able to come up with regulations that might change it within the scope of the statute. So, but with a lot of the programs out there, housing and similar programs that are funded through grants, there is this real tension. Members of Congress have to, when they introduce legislation, they have to have authorizing legislation that gives the agency the ability to spend the money. But then every year they have to go through the appropriations process. And the labor HHS appropriations process, there are 13 separate appropriations bills, and one is dedicated to labor HHS. And there's always such a limited amount of money and such demand for those services. You're competing with the National Institutes of Health and a lot of other really important programs. And some members of Congress are concerned that there may be an attempt to use entitlement programs to circumvent that appropriations process. And so it's a little politically charged. And the other point that I would make is that, the Medicare Trust Fund is certainly, we hear a lot about the solvency of the trust fund and when it's going to run out. And there are a lot of members of Congress that are concerned about that and the cost of adding that a benefit to Medicare and the implication of that on the trust fund. And then also, there are some members of Congress who, while they might support, thinking of vision, dental, and hearing, while they may support individuals having coverage of that, putting it in the Medicare program, which provides the same benefit to everyone regardless of income, many feel is not an adequate targeting of our resources, that you're actually providing services to people who might well be very well off. And so maybe that those resources would be better targeted, creating more incentive for states to expand Medicaid and to cover services for low-income populations. And I'm sorry, that was a very long-winded answer.
Thank you for that.
Barbara, what are your thoughts and comments? Looks like you are muted.
I am muted. Thank you. And Catherine, thank you for that presentation, which was not just incredibly informative, I found it very hopeful. And I'm going to respond to a couple of things, a couple of thoughts I had, without allowing myself to be constrained by political realities. I'll leave that to you and to Kai. So I think that the Build Back Better Act, what it offers in terms of health benefits is very important and very welcome. And some of the things you didn't mention are things like pharmacy and drug caps. certainly alternatives to nursing homes, hearing benefits, which might be available to Medicare patients, and the prevention of exploitation of older adults. I mean, these are all incredibly important. There are two elements I'd like to emphasize. One is, and you spoke about this very eloquently, about the need for support for community-based organizations. And I'm talking about beyond community health centers, community-based organizations that do address the social determinants of health for Medicare beneficiaries. And I believe that while illness treatment lives in the hospital and the nursing home, health and healing live in the community. And it's mostly community-based organizations that help people with these social determinants of health, including the ones that you mentioned: food, transportation, housing. But I would also add breaking down social isolation, which is really crippling for older adults. And you asked about evidence-based research. So here's a quick story. The acute care for the elderly unit of CPMC, which is the Sutter hospital system in San Francisco, and San Francisco Village, where I'm on the board, is undergoing a pilot project for the past 2 years. San Francisco Village is not a geography. It's not assisted living. It is an intentional community of older San Franciscans, and it's an intergenerational community, 400 older adults and about 200 younger members. And we address these social determinants of health. And the project was that for those eligible discharged ACE unit patients, they were given a 3-month membership in San Francisco Village. For the hospital, the hope was reducing 30-day readmissions. For San Francisco Village, the hope was to improve the quality of life. After 2 years of gathering data, the result is that during this 2 years, those members who participated in San Francisco Village events and had volunteers to help them with transportation and meals and become good buddies, there was 0 30-day readmissions. And the Sutter Institute for Advancing Health Equity is in the process of writing a rigorous academic paper on this. So I'll make sure that you get that paper.
Great, thank you.
Another point I wanted to make, in the act, there's a note about caregiver paid leave. And I wanted to make a comment on that caregiver paid leave is much more complicated than sending the caregiver a check and saying, go take a break. Caregivers don't take breaks. They don't leave their partner behind and go to Hawaii, both for the patient's sake and for their own sake. The need is there, but the attachment is stronger. And even when there is some physical distance, the caregiver is still completely focused on the patient back home. So while caregivers do need money, they also need people who can come into the home and be there to do the heavy lifting for a period of time, to monitor medications, bathe and toilet the patient, get the patient dressed, get up 3 or 4 times during the night to help the patient to the bathroom, shower the patient. Caregivers need a reliable helper in an ongoing way. And rather than 4 weeks of paid leave, they need that kind of ongoing support and coverage, not the paid vacation. And one other thing I'd like to note about the BBB Act is that we older adults, we're much more than our health status, and that we care about what most of the things are in the bill. We care about climate and infrastructure and immigration and transportation and affordable housing, and not just for ourselves and our grandchildren, but for the planet. And we are a powerful audience that can be marshaled to support passage of this bill beyond the direct benefit of Medicare and Medicaid improvements. And my question, this is a confusion I have. The we have been inundated, we beneficiaries have been inundated with ads and emails and webinars encouraging us to sign up or switch to Medicare Advantage. And yes, it may cost beneficiaries less than regular Medicare, especially during healthier years, but it restricts beneficiaries to network providers, to the one drug list that that insurer offers, at prior authorization for specialty care. I mean, there are limitations. And I have regular Medicare, and when I compared what I pay to what the Medicare Advantage weighted average out-of-pocket limit is, they're about the same. And so I don't understand why there is this incredible push to switch to Medicare Advantage. And where is it coming from? Who benefits? And I've also heard that for older adults who do have complex conditions and do have the need for multiple specialty care, at that point, they often want to switch back to regular Medicare. But they find that the Medigap insurance may not be available to them at that point. So I'm confused about the push to join Medicare Advantage.
Okay, let me take each of these. First of all, I totally understand what you're talking about when it comes to caregivers. My mother, until 6 weeks ago, lived with my husband and I for, I think, a total of 18 years. And most of it, she was healthy. And, but, you know, about a year ago, she, as you would expect, she fell and broke her hip, and it has just been a decline ever since. We were lucky in that the state of Virginia provided home and community-based services for my mother. So we were able to have someone come in 40 hours a day, 7 days a week to help take care of her. And that worked really well for a while, but we didn't have help during the night. My husband and I both work full time, and we didn't have help during the night. And ultimately she fell and broke her arm, and we had to make the very difficult decision to find a nursing home for her. And that is actually one of the reasons today's my last day at BPC. I am going to take some leave, and by leave, I'm taking 2 months off at least without pay to try to help my mother settle into that nursing home and to get her more comfortable with it and be with her as much as I can. So I think the benefit of the paid leave is, I wouldn't think of it like respite care, in which, you would allow someone to come in and take care of your loved one so you could go on vacation. It's really more, if you think of it more as maternity care. So if paid leave were in place right now, fortunately, my employer has a paid leave policy for parents, but I really would like to take a couple of months off and make sure that she settles. But the paid leave, as it's outlined, is very much like maternity leave. So I could take time off and still receive, it would require my employer to pay a certain percentage of my wages for, I think it's 4 weeks. So I would really encourage you to take another look at that provision, because it's not really paid vacation. It is requiring your employer to allow you to take time off to care for a loved one, just as though similar to a maternity benefit. With respect to social isolation, I think that there is some evidence out there. I agree with you, and certainly so does HHS. If you take a look at the allowable benefits under special SSBCI, special supplemental benefits for the chronically ill, one of the benefits that is there is the plans are permitted to cover the cost of allowing individuals to engage in community events. And so plans could allow individuals to get out and do things. One of the things that they took a little criticism for was things like entrance fees to national parks and other events. So the agency is certainly understanding that there is a benefit to having social isolation. When it comes to Medicare Advantage, you know, I am neither a proponent nor an opponent of Medicare Advantage, but I will tell you that, you know, I was responsible for my mother's care for a long time. And she was paying, it was almost, I think, $400 a month out of pocket for Medigap coverage for a Blue Cross Blue Shield policy. And she couldn't look for a cheaper one because if she let that one go, the new one would be less generous and she couldn't go back to the other one. Instead, what we did was we found a managed care plan for her. And we were able to find one that did include all her providers and it did cover all her prescriptions. So, you know, I can tell you firsthand, there are benefits to Medicare Advantage. It saved my mother a lot of money and we didn't have the problems that you outlined. But I recognize that there are problems with Medicare Advantage and that people do have concerns about it. But, you know, I think that there is a constituency for Medicare Advantage. It's going up. Employees, as they retire, they have been enrolled in managed care, many of them for most of their lives, and they're comfortable with managed care and feel completely comfortable moving into a Medicare Advantage plan. But federal law does provide freedom of choice. So there is nothing that would preclude anyone from continuing to be in Medicare fee-for-service. It's just a matter of comparing the trade-offs. And, you know, I can neither, you know, I can't speak to an individual in a particular area. So I know that there is a lot of support for Medicare Advantage, but there's also a lot of concern too, and a lot of criticism. And we can expect the current administration to really take a hard look at their reimbursement and what's going on in Medicare Advantage to try to rein in some of the costs and address any of those concerns.
Great. Well, thank you so much to both of our discussants and also Katherine for responding to those points. We have about 10 minutes left and there are several questions in the chat. But I want to first just see if either of the discussants wants to take an opportunity to just briefly have an additional comment before we move on to some questions in the chat.
I don't have any additional comments. Thank you for the opportunity.
Sure. Okay. Well, in that case, then I'm going to just go to some of the questions that are in the chat. One of them, and Chris, it comes from Chris Langston, and he may be on, and feel free to add to what I'm going to say. But the question is really getting at what are some of the best options to get social support and social determinants of health services integrated with healthcare and paid for. And he talks about some of the Medicare accountable health communities and SHARPs being things that have been suggested but have limitations or shortcomings. And what do you see as a viable path forward for integrating social determinants of health and social support?
You know, for now, I think that the best options are through Medicare Advantage and through for dual eligibles, fully integrated dual special needs plans. But that said, the Bipartisan Policy Center has put forth a recommendation to expand these services into Medicare fee-for-service, particularly for those who are participating in alternative payment models, such as affordable care, accountable care organizations, and also for those who are being treated by a physician under the chronic care management benefit to allow the primary care physicians to recommend certain services. And the way that we define that was we proposed giving the Secretary of HHS the authority to expand coverage of certain services for certain populations, certain conditions, and incidences where peer-reviewed evidence showed that the intervention will reduce cost over the long term. And hoping that by putting those criteria in place, that there would be a better chance of it getting passed, because our hope was that the Congressional Budget Office, which is the sort of gatekeeper for legislation on the Hill, would take a look at that and say that, and it would have to be certified by the HHS Office of the Actuary. Our hope was that if that can get enacted, that CBO would not score it as a cost, or they would score it as a minor cost, and would provide more flexibility in Medicare fee-for-service for treating patients with multiple chronic conditions. I think certainly CMMI, as Kai mentioned earlier, is an opportunity as well. There have, I think the current CMMI administrator, Liz Fowler, is really taking a good hard look at those programs that have been implemented so far, and is trying to get a real handle on how many of them there are, which ones are actually successful. And hopefully, once she has completed that review, there will be consideration of expanding some of these pilots and demonstration programs.
All right, thanks. There's also another question coming back to Medicare Advantage. And this one is saying that for a person who would not meet the income requirements for dual eligible or the Medicaid waiver program, would you say that Medicare Advantage helps that person receive more services?
I think it really depends on where you live and depends on the plans that are available in your area. My mother actually spent down into Medicaid, and so she was receiving services through a Medicare Advantage plan for, I think, 5 years before she actually qualified for Medicaid as a dual eligible individual. But I can tell you that because there is a lot of competition among Medicare Advantage plans in Northern Virginia, where I live, it was beneficial to her. That doesn't mean that everyone is going to have the same experience with Medicare Advantage. I think it really depends on where you live and who the providers are, who the plans are there.
There are also a few questions about coverage and benefits for particular things, so around prescription drugs and also around hearing devices.
And the question being, I'm sorry.
In one case, it says, is hearing device fully covered, was one question.
It is not under current law. It is proposed for the Build Back Better Act, and it's unclear whether or not that provision will survive the Senate. But I expect that, given that Bernie Sanders is chair of the Senate Budget Committee, he is the primary advocate for it. My expectation would be that there will be some expanded coverage of hearing in Medicare fee-for-service. It is covered in many Medicare Advantage plans, but not all of them.
And then with regard to the prescription drugs, I think it's specifically asking, will the Build Back Better plan extend current ACA coverage for more prescription drugs?
It will. Not only does it maintain the current program, I think the House version also caps out-of-pocket expenditures at $2,000 a year. So for those with exceptionally high drug costs, it would limit out-of-pocket costs for them. There are a lot of, there are other provisions as well that go directly toward the prescription drug industry profit. I'm not prepared to go into those at the moment because I haven't looked at them recently, and I'm not sure what's in Build Back Better. But there are provisions that would actually lower drug costs, out-of-pocket drug costs, not just for Medicare beneficiaries, but generally, I think the expectation is that the other provisions will bring down drug costs. One of them I know is the cost of insulin.
Great, thanks. And then there's an asking for a clarification on a point that you made about housing. This says, I understand you to say that there is evidence of full cost offset, but that the high cost on the front end is so high as to make it politically unacceptable. However, if it's truly a matter of cost offset, isn't there some way of generating the will to front the money and make it back later?
I think that, yes, I did say that. And I think that the concern is twofold. One is whether or not, if you make a benefit like that available in Medicare, it's going to be very costly. And when Congress enacts legislation, they have to typically find a way to pay for it, whether that's raising taxes or cutting other programs. And that has always been a challenge. But finally, as I sort of alluded to before, there are many members of Congress who just really don't believe that it's the responsibility of the Medicare program to pay for housing services, and that it would ultimately cause the program to be insolvent unless you raise taxes or lower eligibility or make other changes to the program to address the trust fund insolvency. So that's not an easy answer, but it's the best I can do. So
That's helpful.
I mean, we've seen just how much trouble we have getting dental and vision and hearing services passed. So I think housing is probably a bridge too far in terms of the Medicare program. But I think there are additional funds in Build Back Better for housing as well, affordable housing.
Thanks. So if I could, I'm going to take the liberty to ask a question myself, which is about mental health provisions. I think there's room to expand there too, but similarly, I sense some of the same sort of maybe reluctance to go too far, particularly for mental health care that would involve long stays in rehab and coverage for substance abuse rehab and that sort of.
I think the good news is that there is a lot of strong bipartisan support right now in Congress for doing something on mental health. The biggest concern that I have heard, and I think the biggest challenge is in the Medicaid program, is that because of the way the program was structured, when it was put into place, it was really the state's responsibility to cover the cost of institutional care, and the federal government would not take on that responsibility in the long term. And so there is a limit on that. There have been proposals to eliminate that prohibition on federal matching funds for inpatient mental health services in the Medicaid program. I think one thing that I had a conversation with a staffer a couple of weeks ago, and the question of mental health coming up in the Build Back Better Act came up. And I think that there is a real sense that, because there is bipartisan support for taking action on mental health services, rather than putting it in a partisan bill that will not enjoy any Republican support at all, I think there is an interest in waiting and doing something next year on mental health on a bipartisan basis. And the committee staff is already working on that. The Senate Finance Committee has issued a request for information and are seeking suggestions on some of the proposals that they've laid out.
Great. Well, that's interesting and certainly sounds strategic. I'm realizing that we are at the top of the hour, and I want to be respectful of everyone's time. we did have one additional question that maybe if you can just answer quickly, and then we'll close, which is, can Medicare Advantage, given that it's provided by private insurers, can it change copays and deductibles and drug lists, or does it require CMS approval to do anything that would change rates?
It depends on what they're trying to change. And there are a lot of rules. Generally, they need to set the drug lists and copays and deductibles at the beginning of the plan year. I think that there are some exceptions for prescription drug coverage changes. I don't remember what they are, I'm sorry to say, but there are limits to what they can change during a plan year.
All right, well, thank you so much. And with that, I just want to thank you again on behalf of all of us at the Aging Initiative. We've really appreciated and learned a lot today from our speaker and also from our discussants. So thanks to everyone. And as you can see here, you will be prompted to fill out a quick survey, if you will, when you leave, and we much appreciate it. Thanks very much.